you come back again a week later, the same thing will happen. You know, the definition of insanity is doing the same thing and expecting to get a different result. And this technique, of course, offers a great way of reassuring patients. And, of course, hopefully we'll hear a bit later, this can be used in the setting of emergency medicine to try and obviate and get rid of this pathway which we all go down, which is expensive, costly, and time-consuming. And the most powerful thing really has been the negative predictive value of CT angiography, i.e. how often are we right when we say there is nothing wrong with you and that turns out to be correct? How often do we say there is no disease present and get it right? And the negative predicted value of CT angiography is very high, 97, 98, 99%, which is wonderful in our ruling out coronary artery disease. The caveat, of course, is, as you've heard before, that what happens if the coronary calcium score is high? So the strength of CT is its relative ease, walk in, walk out, compared to an invasive angiogram, and perhaps the strategy of use, which is now sort of almost in biblical terms enshrined, is that it excludes patients with normal coronaries, particularly those who present with atypical chest pain, and this bugbear of modern medicine and cardiology, the abnormal exercise test in patients who have a low to intermediate probability of coronary artery disease. Talk a little bit about the stress test later and how that fits in. And of course, high-risk cases should not really have a CT angiogram. Someone comes into your rooms, your office, clutching their chest on all fours and getting angina while they raise the GTN spray to their mouth. They actually don't need to have a CT angiogram. In those patients, of course, you go straight to the cath lab. Now, there's been one reference to the sorry events of yesterday, but I couldn't let this go. This is an email that came round from our trust. Cardiovascular events during the World Cup soccer. We'll probably be seeing a lot of these over recent days or weeks. This is actually a study from 2006. And this shows the peak of coronary events during the 2006 World Cup from the Germans at various group stages, peaking, of course, in their semi-final. And the day after the semi-final, the number of acute cardiovascular events shot up and was evident from this graph. And no doubt we'll be seeing lots of admissions with acute coronaries in our own practices. So as I say, high-risk patients are likely to have a higher calcium score. And heavily calcified coronaries have significantly impaired the sensitivity, i.e. the ability to see through the calcium into the lumen, as you've just heard. Now, I've been to umpteen CT conventions and heard all the luminaries talk about this in Europe and the United States, and it seems to vary as to what the cutoff should be as to where your calcium score makes a CT angiogram not useful. And the answer is, I really don't know the answer. I've heard people say, quite honestly, if you've got a score above 400, it's not worth doing. Other people have said if it's above 1,000, don't do it. Some people have said, well, you can get above 1,700, I wouldn't do it. And I think really it's open to negotiation at the moment, depending upon the scanner, the skill of the radiologist, etc., and whether you get the blooming that you see here that really obscures anything behind it. Also, the 64 multi-slice scanners, which are our sort of bog standard workhorse scanners, they have sometimes not been quite as accurate. And I've taken this example to show you a lesion here in the left anterior descending from a conventional invasive angiogram. And you can see just there is a very tight stenosis which involves the left anterior descending and the origin of the diagonal branch. Whereas on the CT scan, the diagonal lesion was actually missed. Now, for the cardiologist, we don't want to have too much of a closed debate among the cardiologists, but there are scenarios, or scenarii, where you might actually regret getting this wrong. Because if you saw this without a bifurcation lesion, you might say, well, that lesion might be suitable for angioplasty and stenting, whereas depending on your level of aggression, skill and confidence, you might in a bifurcation lesion want to send the patient to surgery. So there are cases where some of these scanners, the early generations of scanners, have actually missed lesions and not detected them properly. Now with the modern scanners, this may be less likely because of the improved temporal and spatial resolution, as you've just heard. And here is an example from the Aquilion where you've got calcium here, but you can actually because you don't get so much blooming, you can actually see the lumen of the artery behind, although perhaps not quite so well there, where there's calcium all round it. And the ability also to look at the artery in the short axis view can be done, so you can actually see it end on and make some assessment of the lumen. Now, I think at the moment this is in a state of evolution, and I would not want to kid you that we can see this on every patient with coronary calcification, because we can't. And there are places and times where we just really can't see anything, and we have to accept that, although hopefully that will improve. I was hoping to be able to show you a movie, but as usual, when you put movies onto flash drives, they tend to let you down. But you can see in this case, which you would be able to if it was rotating, 3-vessel coronary disease in the right coronary LAD. What patients actually love to see is the volume rendered images. The patients really love these. They like to take them home because they actually can see their heart, their aorta, and their coronary arteries. And we don't necessarily want to interpret too much from these. We prefer to look at these sort of images, but these are very beautiful to tell the patient what's going on. Now, what about stents? In the literature, there are lots of papers showing how good CT angiography is for looking at in-stent restenosis, stent patency, etc. But I'm going to show you that's not necessarily the case. And this is a study, a paper from an image from the literature showing here a stent in the left anterior descending, and you can see beautifully the contrast going through it and coming out the other end. So that is a perfectly patent stent. Can we rely on this in clinical practice? Well, sometimes not. In this particular image, although you can see more if I could rotate it, you get so much metal there that you really can't see what's going on in the body of the stent. What you can see is there is contrast coming through the other side. And here is a stent which is a very unhappy outcome. This is not one of mine, I'm glad to say. A stent which is completely occluded. There's lots and lots of metal here, and you can see no contrast going through the vessel at all. Just the skeleton of the vessel, the stent outline, but actually hardly any contrast, if any at all. So you can see if the stent maybe is completely patent, and you can see if it's completely occluded. Here is another one that's completely occluded. You see here absolutely no contrast going through the stent whatsoever. But again, let me caution you, this is actually a patient of mine, a very severe diabetic from the Far East, who's had 2 lots of drug-eluting stents. And you can see here, the way this was reported is that there is an outflow obstruction to the stent. And I think we'd all agree with that. You can actually see here what looks like a very tight stenosis with contrast going through here. But again, can you say too much about what's going on inside the stent? Is it diffuse in-stent restenosis, or is it localized outflow stenosis? You can't tell. As it happens, this patient had terrible diffuse in-stent restenosis in both LAD and circumflex and has now undergone surgery. But I don't think we can yet say this technique is the treatment of choice, that we can substitute invasive angiography with this for looking at stent patency in everyday clinical practice. I really don't think we can yet. That's the same patient. So when you talk about the truth, you have to realise that the truth can change and perspectives can change. What proof do you have that Iraq has weapons of mass destruction? Well, we kept the receipts. Now, what about graft studies? I think most of us who use this technique would agree that this is a fantastic imaging technique for looking at graft patency and graft disease. And I think we'd agree it's almost, if anything, is 100% accurate. The beauty of the grafts is they don't move. They sit still, they're nice and close, and you can actually see them beautifully. And you can demonstrate graft patency or otherwise. Here is a patient who had 4 grafts. He's got a patent right coronary graft, an occluded OM graft with a stump, a patent diagonal vein graft, and a patent left internal mammary. We don't really know in cardiology how to follow up patients who are seen 10, 11, 12, 13, 14 years post-bypass surgery. It's one thing to do nuclear MIBI scans or stress echoes once a year and reassure the patient, but the problem is the grafts can go down very quickly, and we all know that you just have to have a small thrombus in a graft, it'll propagate, and the graft can be completely blocked in a day or two, even though your imaging showed that they were getting normal perfusion or normal flow a few days before. I don't know how often we should repeat these studies in patients with patent grafts. We do it in some cases, largely because the patients want to know. Sometimes they have atypical symptoms, and it can be very reassuring if their grafts are patent. Although, of course, remember that if you've got very advanced native coronary disease beyond the graft with lots of calcification, you really won't be able to say anything at all about the native vessels. Now, number 3, what about problem solving? CT angiography is very useful as well where conventional angiography has failed or is high risk or has failed to answer the question. I think for many of us, the internal mammary problem comes back. If you're trying to do a mammary from the leg and you're wiggling around and you're worried the patient's going to have an embolic episode and they don't feel very well and you pull the catheter out, what do? Do you go back from the left radial? Well, no, you can do a CT angiogram to get the mammary. It's very easy to do. But aortic dissection, anomalous coronaries, coronary aneurysms or fistulae, or aortic root dilatation. Sometimes in patients with really, really dilated aortic roots, it's incredibly hard to get a selective coronary arteriogram. And CT angiography here is extremely useful. Let's skip through that one for time. Anomalous coronaries are perhaps not the scourge of the population. But when you find them, no one knows what to do with them. Sometimes they crop up as an incidental finding in angiography, but sometimes you'll investigate a patient who's had a syncopal episode or gets chest pain or has a positive stress test, and you'll find they've got a coronary anomaly. Now, we don't get any physiological information from a CT angiogram, but some of the causes of these coronary anomalies are described as malignant when the vessel runs between the pulmonary artery and the aorta, and during exercise, when the pulmonary artery pressure and the aortic pressure go up, the theory is the coronary artery gets squeezed, makes the territory of the myocardium ischemic and can produce an ischemic arrhythmia. It's very, very hard to prove, but you can sometimes tell from a CT angiogram exactly where the coronary is lying and whether it's being compressed by a vascular structure or not. Complex AV fistulae in the coronary tree are also not the scourge of the population, but it can be sometimes interesting to pick them up. You see a coronary pulmonary artery fistula, very marked AV malformations. You don't get much physiological information from them, but you can see them. The non-coronary indications, of course, well, valve disease. How good is CT angiography for valve disease? Is it better than echo or MRI? I don't think anyone really knows yet. But the electrophysiologists like to have CT available because they can map out the atria for their ablation techniques very, very simply. And so that's one useful non-coronary application. Cardiac tumours, again, we don't see them very often, but they can be incredibly difficult to diagnose. Echocardiography may not help, MRI should, but you can see them here, this very abnormal tissue in the atrium indicating a tumour, and on virtual angiography you can actually see them very beautifully. Now, what about risk stratification? Well, we know about EBCT, and I'm not going to concentrate too much on that, but the way we do it in the UK tends to be from family history, the conventional risk factors, blood pressure, diabetes, smoking, lipids, risk tables, Framingham scores, all the other scores, and the stress test, of course, which is often used in life insurance examination. Now, in clinical practice, that translates into the liberal use of statins, over-the-counter statins, the polypill, and our sort of herd-based approach in the UK to prevention. You know, we chuck statins at a population, hope that some of them will take them and some of them might actually get some benefit. But we don't really know. And is it really good enough in 2010 to do that? So people use the stress test. I do work for one of the life insurance companies, and they ask for a stress test if you need 35 squillion pounds of life insurance. I have failed to make them understand that the stress test is no more accurate if you want £5 million of life insurance than it is if you want £10,000. But nevertheless, they still do it. In spite of the fact there are no randomised trial data to support the use of treadmill testing in asymptomatic subjects, this statement from the AHA scientific group showed that it really isn't a test that should be used in an asymptomatic population, and it actually has class 3 guidelines, which means it's actually useless or may even be harmful. Nevertheless, it is still done. The rapid access chest pain clinics, which I think we're going to hear a little bit more in a minute, uses or has used stress testing for patients that turn up for atypical chest pain or chest pain. 85 to 90% of them get a stress test, and about 30% of those will go on to coronary angiogram.